Welcome to ANA Investigates, a monthly podcast featuring the latest in neurology and neuroscience, brought to you by the American Neurological Association. I'm your host, Adeline Goss. Current guidelines for management of carotid stenosis are based on a series of trials dating back to the 1990s. The NASCET trial, or North American Symptomatic Carotid Endarterectomy trial, and ACAS, the Asymptomatic Carotid Atherosclerosis study. If you were to ask today's guests, they'd say virtually no other area of neurology is so badly in need of an update. Dr. Seemant Chaturvedi and Dr. Cheryl Bushnell join us for a discussion of the major advances in medical therapy for stroke prevention since those trials and why these advances require new trials to refine patient selection for revascularization. They'll also discuss the growing role of plaque imaging in treatment decisions. Dr. Chaturvedi is the Stewart Greenebaum Endowed Professor of Stroke Neurology at the University of Maryland School of Medicine, and Dr. Bushnell is Professor of Neurology, Vice Chair of Research, and Stroke Division Chief at Wake Forest Baptist Health. Here they are.
Hello, ANA Investigates listeners. This is Dr. Seemant Chaturvedi. I'm honored to be joined in today's discussion by Dr. Cheryl Bushnell. We both share a passion for stroke prevention, and we'll discuss some issues pertaining to carotid stenosis today. So what are the treatment options for carotid stenosis? So we have several options, including intensive medical therapy, carotid endarterectomy, and carotid stenting. So carotid endarterectomy is an open surgical procedure in which the plaque is removed from the internal carotid artery to try to improve blood flow to the brain and hopefully reduce the later occurrence of stroke. In contrast, carotid stenting is done as an endovascular procedure with the similar goal of decreasing the area of stenosis for long-term stroke prevention. In the United States, about 80% of the procedures are endarterectomies, and about 20% are carotid stent procedures. So in terms of who do we do these procedures on? So they're currently done commonly for patients with a recent stroke or transient ischemic attack related to the area of the stenotic internal carotid artery. Occasionally, they're done on people who are without symptoms, but who have severe and especially greater than 80% stenosis. There are still some significant uncertainties about who benefits from the procedure and who doesn't. And these uncertainties also include important subgroups, such as men versus women and elderly versus younger patients. And so with that as some background, I think we'll start with some questions for Dr. Bushnell. So Cheryl, the landmark studies, such as the North American Symptomatic Carotid Endarterectomy trial and ACAS, they date back to 1991 and 1995, respectively. This is about 3 decades ago. So can you comment on how the landscape has changed in terms of medical options for stroke prevention?
Sure, Seemant. Well, first of all, prevention options are so much more effective now than they were back in the early 90s. As you know, the major thing they did with those studies was give patients antiplatelet therapy. There was really no management of cholesterol, especially LDL cholesterol. There was really no emphasis on physical activity, blood pressure management, and diabetes management. So there have been so many different types of prevention and risk factor management trials that have happened since then that it really is a totally different time in terms of medical management.
Yeah, those are great points. And also, those early studies primarily used aspirin alone as the antiplatelet agent. Can you comment on do you ever use dual antiplatelet therapy these days for patients with TIA or stroke?
Sure. I mean, sometimes they come in already taking dual antiplatelet therapy because they have known carotid stenosis or have peripheral arterial disease. So, absolutely. Another population are patients with coronary artery disease that may already be taking both. But really, it's kind of a matter of the degree of carotid stenosis and what the plans will be for managing that stenosis. So I'm usually consulting with our interventionalists as we try to decide what to use for antiplatelets.
Now, one of the findings from the symptomatic carotid stenosis trials was that women had reduced benefit from carotid surgery compared to men. Can you comment on some potential reasons why this may be true?
Yeah, I think that there are a lot of differences in the plaque and the stenosis characteristics. So the stenosis is really, the velocity, the diameter of the residual lumen for where blood is flowing. You can have really high risk carotid plaques that are probably more significant than the stenosis itself. And so if you have somebody with like a man who's got 50% stenosis, but really significant ulcerated plaque and poor prognostic characteristics of the plaque versus a woman who has less plaque but more stenosis, you might imagine that the man might benefit more from the procedure. So there are those things, and there are the fact that women are older at the time that they might be identified as having both carotid stenosis and get surgery. And there are probably many other things that we really don't fully understand in terms of the gender differences, but those are just a few that come to mind.
Yeah, those are great observations. Now, as a neurologist, we frequently get consulted for patients following a TI or stroke. And if they're found to have severe carotid stenosis, for example, greater than 70%, we frequently get asked about the timing of the procedure. And so, can you comment on your approach and what are some of the considerations in terms of if you're going to recommend an endarterectomy or stent, what's the optimal timing?
Yeah, I think this has been studied from based on a lot of the trials that you mentioned. And the theory, I think, in practice had been to perform the endarterectomy or stent within 2 weeks, or 14 days. And so that was some analyses of these trials that showed maybe that's the ideal timing. But a lot of times, we have patients in the hospital, they're there, and why not fix the carotid while they're in the hospital? Get it done. Don't wait for them to be discharged and have a stroke, and then you missed your opportunity to really prevent something more major. So as long as they're neurologically stable and the surgeon or the interventionalist is in agreement with the fact that this is a stenosis that should be revascularized in some form or fashion, then I tend to try to encourage this procedure to happen as soon as possible after they're admitted. Now, there is a systematic review of the timing of carotid endarterectomy in particular that suggests maybe within 48 hours might be too soon, but my guess is that you really need to just understand, is the patient stable for having the procedure done, and a lot of those considerations for safety with the procedure itself. So those are just some of my approaches.
Yeah, one pragmatic tool that I use, which some of the listeners might find helpful, is the 1-3-14-28 rule. And that means that for a patient with TIA, you operate quickly, like within 1 day or so. For a mild stroke, within 3 days. For a moderate stroke, between 3 to 14 days. And then for a more severe stroke, reevaluate the patient after 4 weeks and see that is there any point in doing the procedure? Because if there is a persisting severe deficit, it may not be worthwhile to do a revascularization procedure in that type of patient.
That's perfect. I'll definitely remember that because that's a great way to categorize things, and it's very logical.
So, in the last 2 decades, carotid stenting has come on the scene as an alternative to CEA, and it's been touted as a less invasive alternative to endarterectomy. This has been studied compared to endarterectomy in several trials, such as CREST. So, how have you incorporated carotid stenting into your practice?
Well, generally, I would go by the guidelines for when carotid stenting is the most beneficial. And so, based on the CREST results, I typically would consider stenting in somebody who is under the age of 70, and men seem to benefit more than women. But generally, I'm also consulting with our interventionalists, and it's interesting that there are some neurosurgeons even who are more comfortable with stenting than they are with doing endarterectomy. And so I know that there are a lot of surgical considerations to make, and such as the anatomical considerations. And so sometimes that's not something that I can really evaluate myself. So I'm definitely doing this in consort with the surgeon or interventionalist, whoever happens to be the one who might do the procedure. Curious how you approach it, Seema.
Yeah, no, I agree. I think we consider several factors, including the patient's age, how long the lesion is. And for example, some of the current guidelines say that in patients over age 70, endarterectomy is preferable to carotid stenting because over age 70, the patients have had higher complication rate with carotid stenting. Also, if it's a very tortuous and heavily calcified aorta, that can cause more technical issues and access problems. And a long area of stenosis can also increase the complication rate with stenting. On the other hand, if the patient has severe COPD or severe heart disease, those might be some factors which would lean you more toward carotid stenting.
Absolutely. Yeah, I agree completely. All of those surgical considerations are so important. So, Seemant, I have a few questions for you. Whether to operate on asymptomatic carotid stenosis has really been quite controversial for the last several decades. Can you describe where we are with that? What's the current status?
Yeah, the current status is that there is a lot of uncertainty as to whether patients really benefit from endarterectomy or stenting for asymptomatic stenosis. And so, if you take the range where we typically would consider it, which is 70 to 99% stenosis, if somebody has never had a TIA or stroke referable to that, or if they've had a symptom more than 6 months ago, then they're considered asymptomatic. And currently, there's a large NIH sponsored study ongoing in North America and a few international sites called CREST-2. And so CREST-2 is trying to answer the question that in the modern era, is endarterectomy or stenting still valuable for these patients? And so in CREST-2, the patients are randomly assigned to either aggressive medical therapy alone or aggressive medical therapy plus endarterectomy or stenting. And so the good news is that CREST-2 is progressing pretty well with over 1,800 patients enrolled. The ultimate goal is to have close to 2,500. And in terms of the intensive medical therapy, some of the elements include some of the facets that you referred to before, such as antiplatelet therapy, tight blood pressure control with a systolic blood pressure goal of less than 130, LDL goal of less than 70, and then lifestyle modification with attention to smoking cessation, physical activity, etc. And so I think CREST-2 is going to provide us tremendous information about the modern role of endarterectomy and stenting in this population. And I would encourage listeners who see asymptomatic patients to go to the CREST-2 website, crest2trial.org, and try to find their closest center and hopefully refer patients. One of the other fascinating things is the international variation, because in the United States, about 80 to 90% of revascularization procedures are done on asymptomatic patients, whereas in some Scandinavian countries, it's close to 0%. And so that's another sort of fascinating aspect of how practices vary across different parts of the globe.
Yeah, I would agree. And just following my CREST-2 patients and as we enroll here at Wake Forest, it's really interesting to see what's happening as you follow these patients over 2 to 3 years. You don't usually get that clinical experience of seeing, what some of the patients have progressed and some of them have actually had events and some have crossed over for other reasons. So it'll be very interesting to see what the results of that trial are. So, besides antiplatelet therapy and statins, what are other treatments and lifestyle factors that patients should be aware of?
Well, the tent of intensive medical therapy keeps enlarging because there are newer and newer pharmacologic treatments which have been shown to be valuable for vascular disease prevention. And for example, in terms of pharmacologic therapy, we now have some options for treatments of high triglycerides. And there's a medication called icosapent ethyl, which was studied in a trial called the Reduce It trial. And that found that using icosapent ethyl for individuals with triglycerides above 150 led to a significant reduction in overall vascular events and close to a 30% reduction in stroke. And so that's another option that we have in addition to statin treatment. If you really need a profound lowering of your LDL, there are injectable agents called PCSK9 inhibitors, which can lower your LDL down to 30 or even lower. And those have been shown to be useful for reducing vascular events. There are many new diabetes medications which have been found to reduce cardiovascular events. There was a nice review in the New England Journal on this recently. And so this is another option where medical therapy is evolving and is of great relevance to stroke prevention. And then finally, we shouldn't pay short shrift to diet and physical activity. And for example, there have been some studies that adoption of a healthy diet, and especially the Mediterranean diet, can reduce stroke by 30 to 40%. And then finally, physical activity, I think you alluded to before, but Dr. Turan and colleagues looked at patients with intracranial atherosclerotic disease and found that those who had the highest levels of physical activity had about a 40% reduction in major vascular events. And so this is something that we need to encourage all of our stroke patients to consider, but especially those with large vessel atherosclerosis, is to try to engage in physical activity on a regular basis, at least 3 to 5 times a week. And the modern data suggests that this could have significant benefits for the patients with carotid stenosis and other forms of stroke.
Oh, I absolutely agree with you. And the only other thing I would add is smoking cessation. That is so important. And a lot of people who grow up in an area like Winston-Salem, where I live, they're just around tobacco and tobacco products all the time. And they just have no idea that smoking increases the risk of stroke. And it certainly has an impact on carotid stenosis and progression as well. And then the other thing I would add is that the CREST 2 trial has health coaching that's customized for each of their participants. So that's another great way to work on lifestyle changes that are really challenging for people who don't have somebody kind of pushing them and encouraging them. So, another question for you, have there been any advances in carotid imaging that clinicians should be aware of?
Yeah, this is another area where there have been significant developments. And for example, the early studies such as NACIT, they relied on conventional angiography at the time of the patients being enrolled in the trials. But in the recent years, the trend has been toward non-invasive imaging. So at many centers, we do 2 non-invasive tests before recommending a revascularization procedure. And so that would typically include carotid ultrasound plus CT angiography or carotid ultrasound plus MR angiography. And so that's a common practice, but it's variable from center to center. But in addition to that, there's been the development of high resolution plaque imaging. And high resolution plaque imaging using MRI has identified intraplaque hemorrhage as a potential marker of individuals who have higher risk of stroke. And surprisingly, patients with greater than 70% stenosis who don't have intraplaque hemorrhage, their stroke rate can be quite low. And so they may not need a revascularization procedure. And so I think the clinicians in the audience are going to be hearing a lot more about intraplaque hemorrhage imaging using high resolution MRI in the coming years. And hopefully there'll be some further trials to look at whether we should incorporate it into our clinical decision making.
Yeah, that could have a huge impact on how we decide which patients need surgery or stenting. Yeah. So another question, what about screening elderly or middle-aged individuals for carotid stenosis? Are there any new guidelines on doing this?
As a matter of fact, yes. So recently, the United States Preventative Services Task Force weighed in on this issue. And so, just to set the stage, there have been some in the past who have advocated that we should screen individuals, say above 60 or above 70, for evidence of carotid stenosis. And here there are two potential rationales that if you identify high grade stenosis, maybe they could benefit from a revascularization procedure. And then number two, if you identify significant disease, you can identify people who would benefit from intensive medical therapy. But the US Preventative Services Task Force did not really agree with this. And they said that the harms from screening outweigh the potential benefits. And so their latest statement was published in JAMA in February of this year. And so overall, they said because the harms outweigh the benefits, they did not recommend screening of the general population and the middle-aged and older population for the presence of asymptomatic carotid stenosis.
Excellent.
So, Cheryl, I think we've had a great discussion. And in view of the many advances in intensive medical therapy, carotid intervention, and imaging, I think it's clear that we need to have more modern data for clinicians and patients. And we encourage listeners to refer patients to ongoing studies such as CREST-2 so that we can generate new relevant information on this topic. Thanks again for listening.
That was Dr. Seemant Chaturvedi, vascular neurologist at the University of Maryland School of Medicine, in conversation with Dr. Cheryl Bushnell, vascular neurologist at Wake Forest Baptist Health. That's it for today's podcast. If you'd like to hear more episodes of ANA Investigates or submit your own ideas for future shows, you can visit myana.org and click on the Education tab. For ANA Investigates, I'm Adeline Goss.
This has been an episode of ANA Investigates, the official podcast of the American Neurological Association, and an ANA Education Innovation Subcommittee production. Thanks for joining us. To learn more about today's program and to find out about the benefits available to ANA members, including access to an array of educational programs and resources, please visit myana.org. Dr. Adeline Goss is our host. Our producers are members of the ANA Education Innovation Subcommittee, chaired by Drs. Megan Ritchie and Romer Giacaden. This is your editor, Jen Hurley. Copyright, the American Neurological Association.